like to thank KGMOA for giving me an opportunity to speak to this large group of doctors so that I can be able to clear your doubts and also give some information. I know everybody will be knowing about HIV because we have been learning it since our undergraduate days. But things have changed a lot. When I had joined my MBBS, we were very scared of this disease. We thought that we will all be wiped out from this earth. But gradually, with all the NACO, with the help of the government and the WHO and the NACO program, the scenario has changed dramatically to becoming a chronic manageable disease. To discuss about these things, I would once again like to thank everybody first for giving me an opportunity, and also Dr. Bindu and Dr. Sunitha for arranging this program. So I think I would better start off by saying that yesterday was the World AIDS Day, and as you all know, 1981, December 1st was the first case detected. And so in that, that day has been given for by WHO as a World AIDS Day. Everybody knows that. And this year's 2025 theme is overcoming disruption and transforming the AIDS response. The disruption is that since till 2023, there was a large global fund given to the HIV AIDS group of people. But since 2023, the donors have reduced the amount, and to change it to domestic funds, it will take time. So to ask for more funds and to help the people who are affected by HIV AIDS, this theme has been selected. Now, the problem is that since you all must be knowing that these cases are increasing. Earlier, it was mostly considered a disease of a low socioeconomic group. But gradually, if you see now, it is becoming a more of an elite group of people who are getting infected. All the educated ones, the youngsters are getting infected. So this is becoming a problem because these are the pillars of your future. If they are getting affected, what will be our future is really a thing to be discussed. That's why I think post-exposure prophylaxis also plays a very important role, because it's very difficult to change the behavior. But we have to give them an opportunity so that they then don't get infected. With decriminalization of homosexuality, this thing is getting increasing in number. No more patients are coming for registration, and it's heartbreaking to inform you all that even 16, 15 years old children are coming with HIV positivity. So this is a very big thing. We have to start sex education in our schools, and we have to discuss, I think, from our dining table. We need to teach our children what is wrong and what is right, and to choose the correct path. That is more important. Just by educating them is not enough. We have to keep them together and tell them what is right and wrong. From there, the prophylaxis starts. So I think I will start with my PPT. Okay, so I think I will start with my I think, is it visible? Can you see the PPT?
Yes, ma'am. It's visible.
Okay. So, what is the post-exposure prophylaxis? It is just the potential exposure to a blood-borne infection like HIV or HPV. An exposure which happens with a potential. You can, there are standard protocols given by NACO. I will just go through it later, but I will just define how we differentiate an exposure into occupational exposure and non-occupational exposure. Occupational exposure is generally related to the healthcare workers and those in the line of duty which happens. That is fire workers and even policemen. And non-occupational exposure is in which there is sexual activity, unsafe sexual exposure out of the workplace setting. And when you categorize the exposure, how do you categorize it? We categorize it as mild, moderate, or severe. Mild is with small bore needle and small volumes of fluids are involved. In moderate, large volume or percutaneous exposure with solid needle. And in severe exposure, high volume, more volumes of fluid will be involved, such as in accidents with high caliber needles that are more than 18 gauge, or deep wound. If there is a deep wound with significant volume of blood being exposed, and there is an accident in which the materials have been used intravenously or intra-arterial. Sorry, 1 minute. Now, there is one more thing is, we have to use universal precaution wherever possible. And even if wearing of gloves is one standard police precaution, but glove punctures, they do happen. So in cases of an accidental exposure, we have such as discarded needles or dried contaminated blood, the transmission risk remains for a week for HIV. Okay. Now, whenever there is a prick, the risk for HBV and HCV is significantly higher than that of an HIV patient, HIV exposure. So whenever a needle prick happens, don't panic. The risk of HIV is always much lesser than an hepatitis B or hepatitis C infection. So not all the pricks are dangerous. Now, how do you assess the risk of exposure from different body fluids? You see the exposure of body fluids at risk are those with blood, semen, vaginal secretions, CSF, synovial, pleural, peritoneal, pericardial fluids. That is the fluids which are at risk, and then which are not at risk are the tears, sweat, urine, feces, saliva, sputum, and vomitus. But if this is obviously if there is any blood contaminated with that, there is blood present in these fluids, then it becomes high risk. So we have people coming with I have been licked, or the saliva, I have been exposed by saliva, and there is sputum, I have been exposed to the sputum of an HIV patient. It's not that always the sputum of an HIV patient is infective. Only if there is blood in that, it is considered to be infective. Now, see the exposure when there is blood transfusion, the exposure is 98%. See, the volume, of course, is the risk factor here. Whenever there is large amount of blood going into a patient, the risk of transmission is high. And in mother-to-child transmission, if there is no treatment given to the mother, the risk is 20 to 40%, which reduces to 2% if the patient is taking free drug regimen. That is tenofovir, lamivudine, dolutegravir, which has been provided by NACO. And if the patient is not breastfeeding, the risk again reduces to 1%. So you see the amount of transmission which occurs from mother to child without any intervention, and with intervention it reduces to even to 1%. Now in sexual intercourse, you will see that the risk through vaginal transmission is only 0.5 to 1.1%, while with anal sex the percentage is increasing. So this is the point we have to see, that when the patient is a homosexual, or what we term them as men having sex with men, in them the risk is much more higher. That is the reason why we are saying the decriminalization of homosexuality has led to the increased number of HIV patients and many other STDs like syphilis. If you go to the dermat clinic now, the number of VDRL positivity has highly increased. It is alarming to see the number of. I think in the last month itself, we had 50% of patients who were HIV positive. 50% of them were even VDRL positive. So these two, not only HIV, all the other STIs are also increasing. Now, if you see the injecting drugs, needle stick exposure, you will see that the risk is 0.3%. And mucous membrane, splash to eye, and oronasal route, the transmission is 0.3%. 0.09%. Again, I have said earlier that the risk of needle stick injury for HBV is 9 to 30%, and for HCV is 1 to 1.8%. So again, if you see, the risk of HBV and HCV is more than the needle stick exposure with HIV. Now, how do you manage a patient who is exposed with this? What will you do when you are exposed? The first thing is you have to take first aid. Then you have to go to a doctor, or you have to take the drug. First, whatever happens, if you have a needle prick injury, first you remove the glove and wash your hands properly with soap and water for at least 20 seconds. And then please don't use any sanitizers or alcohols or squeeze your finger, because that will only lead to increased risk of transfer of the virus through the blood vessels. So better don't squeeze or use vasodilators like sanitizers or spirits. And then after that, please always take a small history from the patient, because you should be able to assess yourself whether this patient is really having a risk of HIV. First, you have to ask them if they have any infectious disease, and you should always take a small history from this patient. Don't let the patient go away. The patient is admitted with you, you can do an HIV test for him with his permission. But if he is not admitted, then you should please, in our casualties or in our OPs, whenever we are giving a injection to the patient, if you get pricked, please take a small history from the patient to assess whether he has any risk factors, like where he stays. Why I'm telling where he stays, because the people who are staying near the seashore, most of them, we find according to our statistics, we have seen that we have more patients who are affected with HIV or are having some sexually transmitted disease. So these high risk areas, like in Eastport also, we have so many patients who are sex workers there. So any patient who comes with sexual exposure or any needle prick injury from those hospitals, we take it as a high risk area. So these things really matter. So take a small history and then assess the eligibility for PEP. That I will tell you how we do. Then we have to counsel the patient how to take the drug and what are the you should take it regularly at the same time. All this counseling has to be given to the patient. Then, if he really needs the PEP, we'll prescribe it, and then we have to do some lab investigations also, and then we have to keep the patient for follow-up. Now, if you have an exposure, I already said, please don't hook the finger. Now, that is the reflex action which you should not do. Wash the area with soap and water, and do not rub the area. Do not use antiseptics or skin washes. Do not use bleach, chlorine, or alcohol, and consult the designated physician of the institution. That is, we can come to our ART clinic, or you can just call us also. Now, what do you do when you have an exposure to your eyes? You have to irrigate your eyes continuously with either normal saline or water, and by keeping your head back, tilt your head back, and then wash the area properly with that. Irrigation is essential. And please, who are wearing contact lenses, don't remove your contact lens. Keep it with in your eyes and then wash. After washing it, only then you remove, because you don't want to expose the already hidden area, the cornea, with the lens. The lens would be covering the cornea. So if you will remove the lens, you are exposing the area more to that. So keep the lens inside and then wash the area. And this common sense, don't use soap and disinfectant. And then you can consult the doctor. And if it is in the mouth, if some blood or anything has gone into the mouth, then spit it out immediately, rinse the mouth thoroughly, and do not use any soap or anything. And then you can consult the physician. Now, how do you establish the eligibility for PEP? Suppose a patient has been exposed to some fluid. If it is a blood or any other fluid, body fluid or other potentially infected material, and the instrument is contaminated with any of these fluids, then if none of this has happened, no PEP is required. But if it has happened, then you have to assess the type of the exposure. You have to see whether the mucous membrane or the skin is compromised or not, and then you have to see the severity of this thing and how much of the amount of the fluid has been exposed. So if it is small volume and only few drops are there, then you call it as exposure code 1. If it is a large volume and there is a major splash, then it is an exposure code 2. And according to the severity, if there is a percutaneous exposure, depends on the needle bore. If it is small solid needle and with superficial scars only happening, it is still graded as EC2, exposure code 2. But if it is a hollow bore needle and it is a deep injury, we will give it as a code as EC3. Okay. And next is source code. Source code is the patient is HIV positive or not. If it is not, then the patient doesn't need an PEP. But if the patient is positive, again we are dividing it into source code 1 and source code 2, depending upon the viral load and CD4 count. If the patient is asymptomatic, he's a stable patient and his CD4 is high, his viral load is TND, that is target not detected, there is no virus detected. That is actually, that doesn't mean that there is no virus. It's just that the machine which counts the virus is only able to detect, according to Indian standard, it is only 50. In foreign countries, if there is 50 copies, if more than 50 copies, you can see the virus. If it is less than 50 copies, you cannot. In US and all, I think it is less than 20 copies. In India, it is less than 50 copies. And high titer exposure and advanced disease, low CD4 count. That means the virus load is also high. The patient is in stage 3 or stage 4 disease, or the patient has low CD4 count. That is, the patient is coming in our OPD in AIDS, with AIDS. In the ward, he is lying down with AIDS. In such cases, the patient may not be taking the drug. In that case, the HIV source code becomes 2. And if there is another portion in which we don't know whether the patient has come to the OPD and gone back home, in that case, the patient will we don't know the HIV status. In this case, the history of the patient is very important. You get a prick, you keep the patient there, just take a small history. Maybe the patient may not be willing to do an HIV test. That is also problematic because you cannot compel a patient without the consent of a patient. You cannot do an HIV test on him. So in that case, you just take a small history and you can see the area from which he is coming. In that case, I will tell you how to assess that patient. Now, as I said, exposure code 1, small bore needle, small volume, and the source code is 1. That means the patient is on drugs and he is stable. The viral load is also 0, that is target not detected, and the CD4 is high. In that case also, the PEP is not required. But the coming depends on the person. You cannot tell that we counsel the patient that it is not warranted, but they are so nervous and so scared that seeing the anxiety and the apprehension of the person, we most of the time are forced to prescribe the PEP. So this happens many a time. But the next section I will tell where it is recommended. In patients who have small hole needle, but the patient is HIV positive and he is not on drugs, in that case, we recommend PEP. In other cases in which there are thick needles or large volumes of fluids are being splashed on the patient, and even if the patient is having a viral load and the CD4 good, the patient is healthy enough, still in that case we give them PEP. So these are the scenarios if the patient is even if there is HIV positive with controlled viral load, we have to prescribe PEP in these cases where there is large volume of fluid or a large bore needle has been used. And then here, as you see, PEP is recommended for 28 days. And we have to take them every day, same time for 28 days. And before that, we have to do few investigations, which I will tell you later. And in the cases where the source code is unknown, consider PEP if HIV prevalence is high in the given population in the region and with risk categorization. So how we assess the risk that I told you, we have to take a small history, and if can assess the patient's sexual activity and whether he is an IDU user. All these things can be taken from the patient. We are doing it regularly. If you go sit with them, they will tell you. And the counseling of the patient. Now, an exposed person should receive appropriate information about the PEP. Now, when we are giving a drug which is having its side effects and the risks are high, because we are giving them fixed dose combination in which there is tenofovir, lamivudine, and dolutegravir. All the drugs are highly toxic. It has its own side effects. The risk and benefits has to be assessed before giving PEP, and you have to take an informed consent, and it should be made clear that PEP is not mandatory but needs to be taken. Now, you should tell them about the window period, what are the baseline tests, what they do. The baseline tests we do are CBC, LFT, RFT, and viral markers we do. We do the cholesterol and RBS also for them. And then we counsel for safe sexual practices. They should avoid sex during for these 3 months till they are found negative, and they should. It's not that you have to avoid sex. You should do protective intercourse only, and then if it is a lady and she is having a baby who is breastfeeding, she should avoid breastfeeding, and she should, if she is not pregnant, she should prevent getting pregnant also. These things have to be counseled to the patient. Now, I already told a woman who is receiving PEP should avoid pregnancy and breastfeeding. And this is very important. People who come are very scared. They need psychological support, because HIV, still people think that once you get HIV, you get AIDS and you will die. So you need to counsel them properly. And we have counselors who are very specialized in this, and they give them time, and we try to address all their concerns. And the baseline, why we do it, all the viral markers in sexual exposure cases. This I am telling regarding those cases who come after sexual exposure. We think them as high risk behavior patients. So we have to first rule out HIV in them. They don't need pre or post exposure prophylaxis. What they need is treatment for HIV. So in these cases, we always it is mandatory that the patient does viral markers and rule out other STIs also. So now we have added VDRL and TPHA to these cases who come after sexual exposure. So in our this thing, NACO, one has to be clear that NACO only gives free medicines for occupational exposure. No free medicines are given for non-occupational exposure or sexual exposure. That is ruled by our NACO guideline. NACO, they have made it in our guideline. That's not it will not be provided for sexual exposure. And documentation is very, very essential. Now, how do you prescribe this PEP? PEP should be, when it should be started? It should be started as soon as the exposure happens, or ideally it should be done within 2 hours or within 72 hours of the exposure. So if the patient comes after 72 hours, still we give it, but we will tell them that the efficacy or the effectiveness of the drug is not as it is when we take before 72 hours. Actually, what we say is, even if you take, this is actually for sexual exposure also, we tell them that even if you take, the coverage is only 91%. There is still a risk of 9% still lying there. So it is not foolproof. You have to keep coming for follow-up. Otherwise, these people, they don't come back. Now, we have to tell them that they have to come back after 6 weeks, 3 months, and 6 months. Only then we can tell them that they are negative. Because the incubation period is 90 days, till 90 days. So we cannot leave them alone, because they may think that they are negative and they may become positive and they will lose to follow up. So now this drug has to be taken for 4 weeks, 28 days, and counseling to be done by the prescribing doctor. We counsel the patient because they are really psychologically very depressed and they will be very anxious regarding the HIV infection. Now, in case of sexual exposure, assault, PEP should be given to the exposed person as a part of the overall package of food. You all know, you all are working in the health and this thing, so you all must be knowing the post-sexual assault care in which we give PEP and I think EC is also an emergency contraception and treatment for other STIs also. And if it is a pediatric case, you have to inform, you have to notify it to the concerned authority. We had a patient, 17-year-old, who came after sexual exposure, and we had to inform the authority about that. He came after sexual exposure with a female sex worker, and then we had to inform the authority. Now, what are the drugs which are used? Now, an exposed person who is more than 10 years or 30 kg of weight, we give tenofovir 300 milligram plus lamivudine 300 milligram plus dolutegravir 50 milligram once daily for 28 days. Now, and if the patient cannot take, who are contraindicated, maybe there is some other disease on which the patient cannot be given dolutegravir. In that case, we give the tenofovir plus lamivudine plus lopinavir, ritonavir, which is given 2 tablets twice a day. So, you know, the load of the medicine, it is 5 medicines per day. That becomes very heavy for the patient. Earlier, it was tenofovir, lamivudine, efavirenz. That can also be given instead of lopinavir, ritonavir. When I was in my PG days, we had a case in which we had to take these 5 tablets. Those times there was no TLE, this efavirenz or dolutegravir, and taking these tablets was really a big burden. Now it is an easier regimen. ELD is a FDC, 1 tablet for 28 days. Now in children less than 20 kg, sorry, 20 to 30 kg is not needed, but I will still tell you. This less than 20 kg, why don't you give drugs less than 10 years? The reason is tenofovir itself causes bone demineralization and it joint fusion of the this secondary sites. That becomes difficult. So the child may have growth problems. So that's why tenofovir is avoided in them. And we give zidovudine, lamivudine for children less than 10 years or weight who are less than 30 kg. We don't give tenofovir. Instead of that, we give zidovudine and lamivudine for patients who are having hemoglobin more than 9 grams, because zidovudine is notorious in causing anemia to the patients. So only in those patients who are having hemoglobin more than 9 grams, we give zidovudine, lamivudine, dolutegravir. And in patients who have hemoglobin less than 9, we give abacavir, lamivudine, dolutegravir. That is the extra. That is the other line is please avoid. So what we do is first tablets immediately, and then next tablet according to the patient. The convenient time he can take the medicines, that you have to inquire and then tell them to take it every day at the same time for 28 days. Now, this was, I am telling you mainly the NACO regimen which India follows, but I will just inform you about the WHO regimen which is set, that is 2 drug is effective, but 3 drug is preferred. 2 drug regimen in other countries, even the ART has been changed to 2 drug regimen. But actually it is in developed countries only. But 3 drug is preferred because 2 drug is effective only if taken within 24 hours, and 3 drug starts its effect even if taken within 48 hours. Okay, that is what is WHO says. Without PEP, HIV infection is irreversible after 2 to 3 days of exposure. That is the reason why we have to give it within 72 hours. This is a very important point which everyone should remember, that when you get exposed, please come. It is available in, actually, when if you come to medical college, it is available in our casualty, in our ARP center, and even in the OT. So don't think it is a Sunday and it won't be available. It is available in the casualty. First dose you will take as soon as possible. The next day you can come to the ARP center and collect the drugs for the rest of the 28 days. So taking the drug immediately is very, very important. Now, regimens in adults and adolescents is this tenofovir and lamivudine, or emtricitabine can also be given, and dolutegravir is the preferred third drug. Okay, as I told you, WHO has a different thing. We follow the NACO regimen, and in that we give TLD, which is available free of cost in our all the ART centers. And in children, abacavir lamivudine is the preferred backbone regimen in WHO, and ETG is the preferred third drug. Now, where do you need expert opinion? I already told you, in case of HIV status where the source status is unknown, PEP is advised on case-to-case basis. So in that case, it is better you come and take an advice from the experts, and depending on the severity of the exposure and the epidemiological likelihood of transmission, that is the prevalence in the area, we decide how we give the PEP. Do not delay the PEP initiation in cases of known or suspected pregnancy. Just because she is pregnant, don't be hesitant in giving the drug, because if a pregnant patient is affected, there are 2 lives which will be infected. So please don't delay in initiation in these patients. And breastfeeding issues is also a problem. We have to explain the risk and try to counsel the patient to stop breastfeeding. And source patient is on ART. Now, this is also a bit confusing area. A patient who is on ART, and how do you assess the possibility of giving a PEP to that patient? So you should know that sometimes the patient will not be on the first line drug. There are 3 lines of drugs in ART. If the patient is taking a second line and we are giving the first line drug TLD to that patient, in that case, the maybe the drug won't be effective. So we have to assess the drug in those cases in which the patient is taking a second line drug and you are giving a first line drug. So in that cases, we have to take an expert opinion, which is better you refer the patient to the ART center. We discussed the case with our Dr. Arvind sir, who is famous. You all know he is the doctor HOD of ID department. So we consult with him and just we tell him how to give the drug. Now refer to an expert in case of drug intolerance. We have seen with patients who come back with diarrhea, vomiting, and gastritis, and all those cases you have to report. Any major toxicity the patient may have a raised LFT. You have to assess the patient before giving these drugs, because it can cause hepatitis, can cause renal problems. So even if after taking 15 days, patient may come with elevated LFT. So we have to monitor these patients. And baseline laboratory investigations are in person taking PEP. You have to do a baseline. I told you, complete blood count, serum transaminase, but we also do RFTs, RBS, serum cholesterol, and HIV, HCV, anti-HBsAg, and we also add VDRL and PPSA. I told you we are doing extra tests because of the these are the places where we can catch people with other diseases also. When they come, it's better to do things which can give the patient some benefit. We can also try to find out cases like that. Now, a positive HIV status of the exposed person may indicate the need to discontinue PEP, and he has to get registered in the ART and start his treatment. Sorry, there's some glitch happening here. I think someone asked it. Now, follow up. How do we follow up these patients? The patient has to come back on the 7th day, 14th day, 28 days, and after 3 months, after starting PEP, we monitor them for their this thing blood values, so that the patient is safe to continue it for 28 days. And the week 6 and week 12 and 24, we do the HIV test, because the patient may not become positive. The test which we do is the antibody test, that it will become positive only by 6 weeks after the HIV infection. So we do it after 6 weeks. Maybe he is negative at that time. He may become positive after 3 months or 6 months. So we have to keep them under follow-up. And as we already said, we have to avoid blood donation, breastfeeding, and pregnancy. Blood donation is also very important, because that also can lead to infection of another person. And the patient should use universal precaution and refrain from unprotected sexual activities. Adherence and adverse drug reaction counseling has to be done. This is in the follow-up. Now, care pathway, I already told you have to assess the patient, counsel and support, prescription, and then follow-up. This is the care pathway for. And availability of PEP drugs, are available round the clock as in the casualty, in our ART center on Sundays. You can get it in the casualty, and in the OT also we are providing. And if you will ask for we are making it you can come and take a bottle for your hospitals also. In case of any exposure, you can give a stat dose and then send them to the ART center for further full complete PEP. So don't delay. To avoid that, you can keep one bottle of ART. You can send a request to us through email and send a person to collect it. We will provide you with the drug. So at least we can use that immediately after the exposure. In cases, the first dose of PEP, in all cases, the first dose of PEP should be offered as soon as possible, preferably within 2 hours once the decision to give PEP is made. A PEP regimen should be made available for ARV drug stocks in the casualty, OT, labor room, ICU, and emergency ward. We are giving it. So please send, if there is, if you need medicines, please, you can send a mail to us and we can provide you. The exposed person should go to the designated clinic or officer at the earliest, and the hospital staff members must know whom to report for PEP and where PEP drugs are available. These are all NACO regime guidelines. Now, what is to be done is, we always blame that needle prick eye, but what is the best approach to occupational exposure to prevent an occupational hazard? What is the best approach? Best approach is you take precaution, universal precaution. You consider all patients as HIV positive. That is very, very important. Even when when a house surgeon goes into the casualty for the first time, he is very enthusiastic. He will go and do all type of things without wearing gloves. First thing you should learn is protect yourself. The times are gone when you were the hero. Now we are seeing that people are all getting beaten up. So better you take your precaution first and then you become a hero. I always tell my children who come there to take PEP that first what you do is to protect yourself. Then you go to protect others. So what you have to do is universal precaution, primary prevention, avoid occupational exposure to blood or other potentially infected material, and personal protective equipment. No to recapping of. These are all basic things which you should follow. Many a times we miss these things. Standard precaution prevention is the key. Now, always use protective gear when you go for an surgery. Always keep eye shields and consider all blood sample infectious. Follow universal precaution practices, safe handling of sharpness. So these are all basic things. Use needle destroyers, which we all should practice daily. Now, these are notifications and key points which you should remember is HIV transmission to the healthcare professional, a minimal possibility, and implement universal precaution plan in the facility. Consider all patient samples as potentially infectious. And initiation of PEP should be done within 2 hours, preferably within 72 hours. Never be delayed due to unavailability of this process status or HIV testing. Documentation and reporting of each injury or exposure is essential. Wherever this is actually for us where we are practicing this thing. We all document each and every injury and we keep the statistics of things and we try to see where these things are happening more, where the needles are being thrown in the trays. Every day we have one PT coming to us clinic saying that there were needles lying down around. So be very careful, everybody in your hospital. You be strict with the concerned people, the nurses and all about the disposal of the needles. This is very, very important. On this day, actually, it should be reiterated that needle disposal is very, very crucial. The people will be using it, throwing it around, then picking people, then they come, and then there is a big issue about this. So better avoid. Prevention is better than cure. So be very alert about this. Now, if the time allows, I can discuss about the pre-exposure prophylaxis. And not in the NACO, not yet started in the NACO this thing. But if you are interested, I can tell about pre-exposure. Bindu or anybody
can. You can go ahead, no problem.
Huh?
I think that is also an important topic, so you can go ahead.
Okay. Pre-exposure prophylaxis is the use of antiviral medication to reduce the chance of getting infected by people at the risk of acquiring HIV. Now, where this is applicable, it is not in our practice. It is generally for those people who are having partners who are HIV positive or going in for you see, now casual sex has become very, very common. People don't think it as a moral responsibility or it is not our age. We have come from a different age. Our kids are in a different age. So you cannot tell them to do things. They have decided for their own. So better to prevent the infection. We cannot change behaviors of people. So this is for them who are going in for because of the social media. I can only say that because of the social media or because of the apps that are freely available, people don't know to whom they are going. Very, very high risk behavior is seen nowadays. We are getting young doctors. Even we have doctors who are newly registered. 5 or 6 of them are very young children who are doing house agency who are coming with HIV positive. I asked them what is the use of being educated on. I cannot judge them, but still that is the situation now. Even engineers, Technopark in Pulleri Varuna Kanambam, really surprising. ഇഷ്ടം പോലെ പിള്ളേരാണ് വരുന്നത്. It's a very bad state of affairs. അതുകൊണ്ട് I think this is really very important topic to be dealt with. നമുക്കെന്റെ ആവശ്യമില്ല, പക്ഷെ നമ്മുടെ പിള്ളേർക്ക് ഇതിന്റെ ആവശ്യമുണ്ട്. We don't know what they are doing outside. So for them, this is very, very important. But ഇപ്പം നമ്മുടെ നാക്കോയിൽ ഇത് ഇൻക്ലൂഡ് ആയിട്ടില്ല. ചിലപ്പം വരും. പക്ഷെ I will just tell you, the renewed focus of preventive measures. Even if you take pre-exposure prophylaxis, there is 90% chance of getting the infection with sexual exposure. 90% safety and 70% is IV drug use. IV drug direct നമ്മൾ HIV അകത്തോട്ടങ്ങ് കയറ്റുകയാണ്. അപ്പം അതുകൊണ്ട് 70% ഉള്ളതിന്റെ efficacy. And types of drug are oral drugs, injectables and vaginal rings. Oral drugs, tenofovir plus emtricitabine ആണ് കൊടുക്കുന്നത്. പക്ഷേ lamivudine can also be given. And then injectables are injectable carbide to gravel and vaginal rings dapivirine. Regimens, the tenofovir disoproxil fumarate, the TDF plus emtricitabine 1 tablet daily, or you can use lamivudine instead of emtricitabine 1 tablet daily. And US FDA recommends tenofovir alafenamide 25 milligram. This alafenamide is less renal toxic. Baki disoproxil is renal toxic also. Alafenamide is less renal toxic. And then emtricitabine for one tablet daily. So this is less effective in this IDUs. IDUs is injectable drug users and person assigned female sex at birth. These are all terms which are used by US people. but this is the correct term actually. Female sex and IDUs not very effective. Now, HIV positive males with HIV negative females. This is a very difficult area. Male will be positive, discordant couple where the male is positive and the female is negative, and they are planning a pregnancy. 20 days before this we have to start. 20 days of PrEP is recommended before considering the female fully protected from HIV acquisition via vaginal exposure. Before they are planning a family, or they are fertile period of they are planning to have intercourse during that time. 20 days before, if you start the patient on PrEP, patient will be considered to be protected from vaginal exposure of HIV. Now, on demand means the patient is going for a sexual intercourse, means they are planning a party and then they are thinking that may happen. So, they have to take 2-1-1 dose that is 2 tablets 2 to 24 hours before sex, and then 1 tablet 24 hours after the pre-sex dose. 24 hours കഴിഞ്ഞ് ഈ സമയത്ത് തന്നെ ഒരു ടാബ്ലറ്റ് കഴിക്കുക. എന്നിട്ട് നെക്സ്റ്റ് ടാബ്ലറ്റ് should be taken 1 tablet 48 hours after the നമ്മൾ ആ പ്രീ സെക്സ് ആ സമയത്ത് ബിഫോർ സെക്സ് 48 hours after. അപ്പം 2 എടുത്തു കഴിഞ്ഞതിന് ശേഷം 24 hours കഴിഞ്ഞിട്ട് ഒരെണ്ണം റിപ്പീറ്റ് ചെയ്യുക, അടുത്ത 24 hours കഴിഞ്ഞിട്ട് ഒന്നുകൂടെ റിപ്പീറ്റ് ചെയ്യുക. Now, carbitographin. Now, this thing, it's an intramuscular injection. It is taken once a month for first 2 months. For who is having a partner who is positive. It is generally used by MSM people. Once a month for first 2 months, then every 2 months thereafter. They may be having stable partners. They can use this carbitographin once a month for first 2 months, and then every 2 months thereafter. Protection achieved 1 week after the first injection. WHO recommends as a part of comprehensive HIV prevention approach. These are all available in Western countries. India is active to use. Maybe private sector use item. NACO is not available. And dapivirine vaginal rings are also used. The long active user controlled and the ring must be placed for 24 hours before it can reduce the risk of HIV infection. And it has to be replaced every month. And HIV prevention product, this is to be approved. It is in the line of this thing, it is there. I hope this has been a informative this thing for you. Any help, you can call us. If you want, I can give you my number also. Actually, you can get in touch with Dr. Bindu. She knows my number. Any doubt, you can call me personally. And any references, you can please send the patient to Trivandrum Medical College, TRT. I hope, Bindu, my presentation is over. You can.
Thank you so much, Dr. Deepti. That was really nice and very crisp and very informative. Can we have a question? Some queries are there in the chat box. Plus, anybody has any doubts, ഒന്ന് unmute ചെയ്ത് ചോദിക്കും. എന്തെങ്കിലും doubts ഉണ്ടെങ്കിൽ clarify ചെയ്യാം. Chat box ഉള്ള doubts ഞാൻ വായിക്കട്ടെ, Dr. Deepti.
Yeah.
Okay, can we give PEP to private hospital staff at free of cost from ART center? That's from Dr. Janardhan Naik sir. Kasaragod ART വർഷങ്ങളായിട്ട് senior medical officer ആയിട്ട് വർക്ക് ചെയ്യുന്ന സാറിന്റെ ഡൗട്ട് ആണ്.
സാറ് ഞങ്ങളെക്കാൾ സീനിയർ അല്ലേ?
അതെ, മേ ബി സാർ ഈ ചോദ്യം ചോദിക്കുന്ന ബാക്കി എല്ലാവർക്കും ഒന്ന് അവെയർ ആവാൻ വേണ്ടിയായിരിക്കും.
Actually, private institutions വരുന്ന ആൾക്കാർക്ക് നമ്മൾ കൊടുക്കാറില്ല. They have to, their hospital should make it available for them. But in many a case time we help them when it's not that it's the line of duty. So ഞങ്ങൾ എങ്ങനെയെങ്കിലും അറേഞ്ച് ചെയ്ത് കൊടുക്കും, പക്ഷെ actually it is not allowed. Their hospital should arrange for them because they have the patient got exposed in their hospital, not private attack. We can give. If it is available, stock in London, you can do. We provide to our patients.
Okay. Okay. If we have blood sample taken from some other reason from the source, can we do HIV testing without their consent?
No,
If
no,
so,
no, we
how
cannot.
to deal with a positive result?
No, we cannot. There is before going in for an HIV test, there is pre-test counseling, and after the patient becomes positive, there is post-test counseling also. Without the consent of the patient, you cannot do it. Even സ്നേഹയിലൊക്കെ നമ്മൾ പോകുമ്പോൾ HIV pregnant patientsനെ പോലും നമ്മൾ കൺസെന്റ് ഇല്ലാതെ ടെസ്റ്റ് ചെയ്യാറില്ല. You have to take consent.
How to deal with an exposure while infiltrating ERIC locally into the muscle and the drug splashed into the eye?
I actually, ഞാൻ പറഞ്ഞല്ലോ, if you get exposed to that, you have to give irrigation to the eye. Exposed ആയിട്ടുണ്ടെങ്കിൽ irrigate ചെയ്യണം. Risk കുറവാണ് because you're infiltrating the muscle, the risk is less. But still, you take the first aid and then there is, most of the time it is not necessary. IM ആണെങ്കിൽ there is no need actually.
Dr. Sunitha Jayadevan, please share the material. All the videos will get uploaded within 1 or 2 days into the KGMOA.
Hello? I cannot hear you.
Can you hear?
Now it's audible.
It's audible. Okay. ഒരു ഡൗട്ട് കൂടെ ഉണ്ട് അവിടെ ചാറ്റ് ബോക്സിൽ. One of our attender got a needle prick while carrying biomedical waste. Unknown patient. So how to manage? Maybe from old needle.
Yeah, old needle ആകുമ്പോൾ ഒരു ഇതുണ്ട് that the HIV doesn't stay more than 1 week on dry surfaces. അപ്പൊ ഓൾഡ് നീഡിൽ ആണെങ്കിൽ if you have to assess when was the needle all collected. ഒരു 1 week കൂടുതലായിട്ടുണ്ടെങ്കിൽ there is very less risk of HIV. There is no need actually to give the HIV to the patient, PEP to the patient. അത് നമ്മൾ ഹിസ്റ്ററി എടുക്കണം. When was the lot collected and where was it collected from? നമ്മുടെ ഇപ്പൊ ഐഡിയിലൊക്കെ പേഷ്യന്റ് ഉണ്ടെങ്കിൽ അവിടുന്ന് വരുവാണെങ്കിൽ the risk is high because the patients of HIV are admitted there. അങ്ങനെയാണ് നമ്മൾ അസസ് ചെയ്യുന്നത്. So where the needle has been collected, how many days old is the needle was. റിസ്ക് ഉണ്ടെങ്കിൽ then we will decide. അത് ഹിസ്റ്ററി എടുക്കണം.
ആർക്കെങ്കിലും ഡൗട്ട് ഉണ്ടെങ്കിൽ ഒന്ന് അൺമ്യൂട്ട് ചെയ്ത് ചോദിച്ചോണേ. ഡൗട്ട്സ് ഒന്നും ഇല്ലെങ്കിൽ നമുക്ക് മാഡം നമുക്ക് ഡൗട്ട്സ് ഒന്നും ആരും ചോദിക്കുന്നില്ലെങ്കിൽ എനിക്ക് തോന്നുന്നു ഇപ്പൊ ഒരു ഡൗട്ട് വന്നിട്ടുണ്ട് ചാറ്റ് ബോക്സിൽ. അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാം എല്ലാവർക്കും. ഓക്കെ. Few years back, hepatitis B groups found due to infections acquired from barber shops, dental clinics. Can HIV also happen like that?
You see, we should always make it a point that you go to a center where they are using blades, fresh ആയിട്ടുള്ള blades യൂസ് ചെയ്യുന്ന ഷോപ്സിലേ പോകാൻ പാടുള്ളൂ. നമ്മള് we should be see if they are using needle prick പോലെ തന്നെയല്ലേ, if they are using it on one blade വെച്ചിട്ട് തന്നെ ഒരേ ആളിനെ തന്നെ വീണ്ടും വീണ്ടും ചെയ്തുകൊണ്ടിരിക്കുമ്പോൾ റിസ്ക് എപ്പോഴും കൂടുതലാണ്. There is a risk, but you should make it a point that they remove that ഷേവിംഗ് റേസറിലെ ആ ബ്ലേഡ് അവർ ചേഞ്ച് ചെയ്തിട്ട് ഫ്രഷ് എല്ലാ പ്രാവശ്യം യൂസ് ചെയ്യാൻ പറയണം. അങ്ങനത്തെ ബാർബർ ഷോപ്പിലെ പോകാൻ പാടുള്ളൂ. There is always a risk because if they are using used razor on every patient, every person, then the razor can cause an injury, no? അത് തന്നെ വീണ്ടും വീണ്ടും യൂസ് ചെയ്താൽ അത് റിസ്ക് ഉണ്ട് തന്നെ.
ഡോക്ടർ വിനോദിന് ഡൗട്ട് ഉണ്ട്, പക്ഷെ അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റുന്നില്ല. ഡോക്ടറിനെ അൺമ്യൂട്ട് ചെയ്യാൻ. ഡോക്ടർ വിനോദ് ചോദിച്ചു.
മാഡം ഒരു 2 ഡൗട്ടായിരുന്നു മാഡം. ഇപ്പൊ നമുക്ക് മിക്ക പി എച്ച് സികളിലും ഇപ്പോൾ ഇൻക്വസ്റ്റിന്റെ ഭാഗമായിട്ടൊക്കെ നമ്മൾ PEP മെഡിസിൻ വെക്കുന്നുണ്ട്. അപ്പൊ അതിന്റെ സ്റ്റോറേജ് എങ്ങനെയാണ് മാഡം? പ്രത്യേകിച്ച് അതിന്റെ ടെമ്പറേച്ചർ എന്തെങ്കിലും പ്രത്യേകിച്ച്?
അങ്ങനൊന്നുമില്ല. It can be kept at room temperature. No need to keep it in the fridge or anything. പേഷ്യൻസ് കൊണ്ടുപോകുന്ന അവരുടെ വീട്ടിൽ കൊണ്ടുപോയി ബോട്ടിലിനകത്ത് വെക്കാണ്. ദേ നോട്ട് കീപ്പിംഗ് ഇറ്റ് ഇൻ ദ ഫ്രിഡ്ജ് ഓർ ഇൻ ദ ടെമ്പറേച്ചറുമായിട്ടൊരു ഇല്ല.
ഓക്കെ മാഡം, പിന്നെ ഒരു കാര്യം കൂടെ.
ഒത്തിരി അങ്ങ് ഓപ്പൺ ചെയ്ത് വെക്കരുത്. നമ്മുടെ ഇവിടുത്തെ ഈർപ്പം ക്യാൻ ഡിസ്ട്രോയ് ദ മെഡിസിൻ. സോ കീപ് ഇറ്റ് ടൈറ്റ്.
ഓക്കെ മാഡം, പിന്നെ നമുക്കൊരു കാര്യം, നമ്മുടെ സോഴ്സ് മിക്കവാറും നമ്മുടെ ഇൻസ്റ്റിറ്റ്യൂഷനിലായിരിക്കുമല്ലോ. അപ്പോൾ നീഡിൽ പ്രിക്ക് സ്റ്റാഫിന് കിട്ടുകയാണെങ്കിലേ, അപ്പോൾ അത് സോഴ്സിന്റെ HIV നമ്മുടെ ടെസ്റ്റ് ചെയ്യുന്നത് പ്രത്യേകിച്ച് നമ്മുടെ ICTC എന്നൊക്കെ അവൈലബിൾ ആയിട്ടുള്ള കിറ്റ്സ് മതിയോ? കാരണം നമുക്ക് അവിടെ ഒരു പ്രിക്ക് ഉണ്ടായ സമയത്ത്
ICTCയിലെ കിറ്റ് ഇസ് വെരി എഫക്റ്റീവ്. 99.9 ആണ് അതിന്റെ പെർസെന്റേജ് ആണ് സെൻസിറ്റിവിറ്റി ആൻഡ് സ്പെസിഫിസിറ്റി. അപ്പൊ ഡോണ്ട് വറി, ദാറ്റ് ഇസ് എ ഗുഡ് കിറ്റ്. ICTCയിൽ നമ്മുടെ നാക്കോ തന്നെ പ്രൊവൈഡ് ചെയ്യുന്ന ICTC HIV കിറ്റ്സ് ആണ്. നോ പ്രോബ്ലം, ദേ ആർ ഗുഡ് സ്റ്റാൻഡേർഡ്.
ഓക്കെ ഓക്കെ.
വേറെ ആർക്കെങ്കിലും എന്തെങ്കിലും ഡൗട്ട്സ് ഉണ്ടോ ചോദിക്കാൻ? എനിക്ക് തോന്നുന്നു അങ്ങനെ ആണെങ്കിൽ സുനിത മാഡം വൈൻഡ് അപ്പ് ചെയ്യാം നമുക്ക്. എനിക്ക് തോന്നുന്നു മാഡം ഓഫ്ലൈൻ ആയിപ്പോയി. അഭിലാഷ് സാർ?
മാഡം ഒരു ചോദ്യം കൂടെ വന്നിട്ടുണ്ട്.
ചോദിച്ചോ സാറേ, അത് വായിച്ചു.
സ്ക്രാച്ച് ബൈ എ പോസിറ്റീവ് പേഷ്യന്റ്.
വായിച്ചു സാർ.
മാഡം വായിച്ചോളൂ, കുഴപ്പമില്ല.
Scratch by a positive patient on treatment with minor bleed, what to do?
On treatment patient ആണെങ്കിൽ അയാളുടെ you should see പേഷ്യന്റിന്റെ വൈറൽ ലോഡ് ഒക്കെ നോക്കണം. If the patient is viral load is suppressed and CD4 is good, there is no need for PEP. I told you, na, source code 1 ആണെങ്കിൽ there is no need for PEP. If scratch ആണെങ്കിൽ ഇത് നെയിലുമായിട്ട് ബന്ധമില്ലല്ലോ. There is no blood in the nails, no. ബ്ലഡ് വേണം. ഏത് ഇതിലായാലും പേഷ്യന്റിന്റെ ബ്ലഡുമായിട്ടുള്ള എക്സ്പോഷർ അല്ലെങ്കിൽ ഫ്ലൂയിഡുമായിട്ടുള്ള എക്സ്പോഷർ വേണം. നെയിലിൽ സ്ക്രാച്ച് വെച്ചിട്ട് പേഷ്യന്റ് ഓൾറെഡി ഓൺ ART, no risk of infection. But if it is a blood stained scratch, then you will have to think.
I think ഏകദേശമൊക്കെ ഡൗട്ട്സ് ക്ലാരിഫൈ ചെയ്തെങ്കിൽ നമുക്ക് വൈൻഡ് അപ്പ് ചെയ്യാൻ തോന്നുന്നു. മാഡം
മ്യൂട്ടായിരുന്നു. എന്തായാലും
ഒരു പ്രശ്നമുണ്ട്. ആരെങ്കിലും അങ്ങനെ ഡൗട്ട് ഉണ്ടെങ്കിൽ ചാറ്റ് ബോക്സിൽ ടൈപ്പ് ചെയ്യണേ. ഐ തിങ്ക് ദർ ഇസ് എ പ്രോബ്ലം. കുറെ പേര് മ്യൂട്ട് ആയിട്ട് ഇരിക്കുന്നത്, അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റുന്നില്ലെന്ന് പറയുന്ന ടെക്നിക്കൽ ഇഷ്യൂ ആണ്. എന്തെങ്കിലും ഉണ്ടെങ്കിൽ പെട്ടെന്ന് ചാറ്റ് ബോക്സിൽ ടൈപ്പ് ചെയ്താൽ വി ക്യാൻ. ഓക്കെ, ഹൗ ടു ടാക്കിൾ മിസ് ഡോസ് ഇൻ PEP?
You see, you should not miss the dose. First of all, you should not miss the dose. Keep an alarm. At the same time, you have to take. So miss ആയെന്ന് വിചാരിച്ചു, you have to take it as soon as you remember it. But within 12 hours എന്തായാലും കഴിച്ചിരിക്കണം. Because after 12 hours repeat dose ചെയ്യരുത്, because 2 doses a day ആവും. അപ്പം as soon as you remember the dose, you take it. It's not that 7 PM പറഞ്ഞു കഴിച്ചില്ല അപ്പോൾ അത് മിസ് ചെയ്ത്, അങ്ങനല്ല. You can take the drug immediate whenever you remember till the next 7 AM. Means അടുത്ത day 7 AM വരെ നിങ്ങൾക്ക് അത് കഴിക്കാം. അപ്പൊ ഓർത്തിരിക്കുമ്പോൾ അതും കഴിക്കാം. You should not miss it. That is very, very important. Carry your tablet wherever you go.
Okay, Dr. Srikanth ഒരു ഡൗട്ട് ചോദിച്ചു. ബിഫോർ ഹെൽത്ത് കാർഡ് സർട്ടിഫിക്കറ്റ് ഇഷ്യൂയിങ് for barber shops and beauty parlor personals, should we make them to do a HIV test?
No, it's not. You should go and read HIV AIDS Act. It is very, very important. Everything is in support of HIV patients. Nothing is supportive of doctors. But HIV Act എല്ലാവരും അത്യാവശ്യം പഠിച്ചിരിക്കണം. Because people are going, അതെനിക്ക് പറയേണ്ട ഒരു കാര്യമാണ്. Every talk I make it a point that HIV AIDS Act you should go and read. It's very, very important because our patients, ഈ portion of the country, Kerala, is very, very active in suing doctors. When they are going in for cases, discrimination, stigma, even if you disclose somewhere without their permission, they are all going to for legal action. അപ്പം ഒന്ന് റീഡ് ചെയ്യുന്നത് നല്ലതാണ്. വേണമെങ്കിൽ ഇതിനു വേണ്ടി ഒരു ക്ലാസ് കൊടുക്കാം. ബിക്കോസ് വി മേക്ക് ഇറ്റ് എ പോയിന്റ് ദാറ്റ് എവറിബഡി ഒരു രീതിയിലും ഡിസ്ക്രിമിനേഷൻ ചെയ്താൽ അവർ പോയി ഇപ്പോൾ കേസ് ചെയ്യുന്നുണ്ട്. ദേ ആർ നോട്ട് സ്കെയർഡ് എനിമോർ. പണ്ടൊരു സ്റ്റിഗ്മ പോലെ കണ്ടിരുന്നേ, ബട്ട് നൗ ഇറ്റ് ഹാസ് ബിക്കം എ നോർമൽ തിങ് ഇൻ ദിസ് തിങ്. സോ ദേ ആർ, ബിക്കോസ് ഇറ്റ് ഇസ് ബിക്കമിങ് ക്രോണിക് മാനേജബിൾ ഡിസീസ് പോലെ ആയി തീരുവാണ്. അപ്പം ദേ ആർ ലിവിംഗ് വിത്ത് ഇറ്റ് ആൻഡ് ദേ ആർ ഗോയിങ് ടു മെനി ഡിപ്പാർട്ട്മെന്റ്സ്, നെഫ്രോളജി, എല്ലായിടത്തും പോകുമ്പോൾ ഇവർക്കൊരു ഡിസ്ക്രിമിനേഷൻ തോന്നിക്കഴിഞ്ഞാൽ അവർ ദേ ആർ ഗോയിങ് ആൻഡ് ഫൈലിംഗ് കേസസ്. സോ ബി വെരി കെയർഫുൾ. ക്വസ്റ്റ്യൻ എന്താണ് ജസ്റ്റ് ഗിഫ്റ്റ് ഔട്ട്. Question is
The
that
question is like if with the health certificates will be asked for
Ah,
barber shop
you
and
are
all.
not allowed. You are not allowed to do that testing. അത് അതിന്റെ ആവശ്യമില്ല. ബാർബർ ഷോപ്പിലൊക്കെ പോയി ഈവൻ കുക്കിങ്ങിനും കാര്യങ്ങളും ഒക്കെ പോകുന്നതിന് ബ്ലഡുമായിട്ട് ഒന്നും വരുന്നില്ലല്ലോ കോണ്ടാക്ട്. ഫ്ലൂയിഡ്സുമായിട്ട് കോണ്ടാക്ട് വരുന്നില്ല. യു കെ നോട്ട് ആസ്ക് ദം ടു ഡു എൻ HIV ടെസ്റ്റ്. ഇറ്റ് ഇസ് നോട്ട് കറക്റ്റ് കേട്ടോ. ഇത് ഇറ്റ് ഇസ് അഗൻസ്റ്റ് ദ ആക്ട്. ഇഫ് ദേ ഡു ഇറ്റ് ദേ ക്യാൻ ബി ക്രിമിനലൈസ്. പിന്നെ വേറെ ഒരു ക്വസ്റ്റ്യനും കൂടെ ഞാൻ കണ്ടു.
Unknown
Tattooing.
source started 3
Tattooing.
days ART and dropped. Oh, tattooing, yeah.
Tattooing
Tattooing
is, you should always, there is no contraindication for tattooing. You should do it in a licensed area where they do it under ഈ റോഡ് സൈഡിലൊക്കെ പോയി ചെയ്ത് കഴിഞ്ഞാൽ പക്ക കിട്ടും നിങ്ങൾക്ക്. പക്ഷെ നിങ്ങൾ ലൈസൻസ്ഡ് ഏരിയയിൽ പോയി ചെയ്ത് കഴിഞ്ഞാൽ there is no risk of HIV. They do it with sterilized needles. അതെല്ലാം be assured before going and doing it that they do it under sterilized conditions. They are using the new ink. They are using the new needle. ന്യൂ പോട്ടിനാണ് അവർ ലിങ്ക് എടുക്കുന്നത്. അതെല്ലാം നോക്കിയിട്ട് വേണം നിങ്ങൾ അത് പോയി ചെയ്യിപ്പിക്കാൻ. ഗോ അറ്റ് ലൈസൻസ് പ്ലേസസ്. Don't go it for. I have seen people sitting and doing tattooing on people in the market. എന്ത് സ്റ്റെറിലിറ്റി ഉണ്ട്. ഒരെണ്ണം തന്നെ 10 പേർക്ക് കുത്തി കുത്തി കൊടുക്കാണ്. So don't go and do it in a local place. Go and do it in a licensed place.
Sajina is asking, unknown source started 3 days ART and dropped. Should he continue from the first dose itself?
Yeah, you have to continue from the first dose. സ്റ്റോപ്പ് ചെയ്തിട്ടുണ്ടെങ്കിൽ അത് the efficacy will go down. അത് പറയണം. Because if you are stopping it, means what do you say, അതിന്റെ എഫിക്കസി കുറയും. നിങ്ങൾ സ്റ്റാർട്ട് ചെയ്തിട്ട് പിന്നെ ഗ്യാപ്പ് കൊടുത്തില്ലേ, പറഞ്ഞില്ലേ 3 days കഴിയുമ്പോഴത്തേക്ക് ഇതിന്റെ റെപ്ലിക്കേഷൻ വീണ്ടും സ്റ്റാർട്ട് ആവും. അപ്പൊ അതുകൊണ്ട് if you are starting, you have to start from the beginning.
Chat box la doubts എല്ലാം cleared ആയെന്ന് തോന്നുന്നു. Madam, 9:59, so I think we can wind up. Sunitha madam.
യെസ്, വളരെ 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 നല്ലൊരു ക്ലാസ് ആയിരുന്നു. എല്ലാവരും ഡൗട്ട്സ് എല്ലാം ക്ലാരിഫൈഡ് ആയി. തീർച്ചയായും നമുക്ക് വളരെ ഇമ്പോർട്ടൻ്റ് ഉള്ള ഒരു ക്ലാസ് ആണ് ഡോക്ടർ ദീപ്തി എടുത്തത്. താങ്ക് യു സോ മച്ച്. യു ഹവ് എക്സ്പ്ലെയിൻഡ് ഇറ്റ് സോ വെൽ. താങ്ക് യു സോ മച്ച് ഫ്രം ദി സൈഡ് ഓഫ് KGMOA. താങ്ക് യു.
താങ്ക് യു മാഡം.
Thank you, Dr. Deepti. വളരെ നല്ല സെഷൻ ആയിരുന്നു. So I think we can wind up. Okay. Good night.
Thank you, Dr. Bindu.
Okay, thank you all.
Thank you all.